So good morning to everyone. First, I want to thank for the possibility to have an interesting talk on the given topic. Does the approach improve or influence the choice of the implant type? At first, when I read the title of this topic, I think, yes, it is easy. I will find a lot of literature to this, and I think there will be a clear way to do it nowadays. But in the end, it wasn't that clear. So maybe I should start at the beginning. I'm from Austria, and like we heard yesterday from Switzerland, Austria is also quite a small country. And over decades, we were really impressed by Professor Zweimüller and his stem, which was widely used in Austria, the Zweimüller straight stem, with a market share about 60% in the 90s, and nowadays still about 30%. And the experience in our department has been over 20 years long. And the design characteristics of these stems are it's a straight stem, it has a rectangular design, it's tapered, it's made of titanium, and the data shows that it has a good rotational stability and a very good diaphyseal press fit. So the question for us was, should we change a winning team? Straight stems have a good long-term survival rates with nearly 100% after 10 years. So we started to dig a bit deeper, and we did a follow-up examination of these alloclassic stems with 10 years data. We looked after nearly 180 stems, and we find the Harris hip score is great, 99% and 99 points. The survival rate was also very good, about 99% after 10 years. We find 4 intraoperative fractures, which is about 1.5%. And the thing which was really surprised was we find 13% clinical detectable gluteal insufficiencies, and I think that's quite a high amount of patients. So where was the problem? Maybe the bone loss during preparation. The disadvantages are quite clear. The straight stem needs a straight preparation. So we took the lateral approach, we did some muscle detachment, and we did some traumatism of the greater togehter. And if you see here on the bottom of the slide, the surgical instructions of the company, you have to do some violation to the greater trochanter bone to get the stem in. So nowadays, the demands for THA are quite clear. You don't want any wear, low stress shielding. It should never loosen. It should be inserted accurately and easily. There should be optimal biomechanical design. It should be a stress-adapted material design, provide excellent range of motion, minimal required bone loss upon implantation. It should be easy to revise if necessary, and there should be minimal tissue trauma, and the anatomical reconstruction as far as leg length and offset is concerned should be perfect. And if we have a real true site on our stem, it doesn't meet all the goals. So what are the main problems? I think the greater trochanter fractures and the bone loss in this area, the stress shielding, the patient popularity is getting younger, and so we have to deal with more revisions in the future, the gluteal insufficiency and the offset reconstruction. And how can we solve these problems? I think with change of the approach, in our case with the MRS approach, we could afford a real effort in the greater trochanter sparing region, and we could avoid the gluteal insufficiency. But only in combination with the stem design, we could afford all of these goals. So what was our next step? We changed the approach. Yes, we did. We changed the prosthesis. Yes, we did. We changed the prosthesis first and the approach second. Yes, we did. And the last 2 points I wouldn't advise to anyone. So approach first, prosthesis second, isn't this a good idea? And I think the worst idea is to change both simultaneously. What are the approaches to the hip? The most common approaches is the medial for specific cases, the anterior, the anterolateral, the transgluteal, the transtrochanteric, the posterolateral, and the posterior. And in Central Europe, especially in Austria, I think these 3 approaches are the most common one. So the anterior approach, you can do it in a supine position with or without extension table. You use the interval between the muscle sartorius and the muscle tensor fasciolate. In this approach, the nervus cutaneus femoris lateralis is a bit at risk, but you can avoid this with a good technique. The exposure of the accetabulum is extendable. It's a bit more complicated for revision cases, and what I think for short stems is very important, you can use it with fluoroscopy intraoperatively. and it's MRS proof, definitely. The anterolateral approach, you can do it in lateral or supine position. You use the interval between the gluteus medius muscle and the tensor fasciolate muscle. And if you do it with the right stem in the right technique, no muscle detachment is there. And the fluoroscopy is also available as long as you do it in the supine position. And it's good extendable for revision cases. And it's MRS proved. So the last one, our old approach, was the direct lateral approach. It can be done in lateral or supine position. You need definitely some muscle detachment, especially if you use the straight stem. The sciatic nerve can be irritated with the retractors when you have to elevate the femur to get into the proximal femur. Fluoroscopy is also intraoperatively possible, and it's very good expensible for revision cases. But it's not MRS proved. The advantages of MRS are well known. You have smaller skin incision, which is for many patients a topic. You have less soft tissue trauma. You have reduced blood loss. You have less operative pain, and you have a faster recovery. But there are also some disadvantages of these invasive and minimal invasive THAs. They are more prone to complication. They are technically a bit more demanding. The learning curve is a topic. The component malpositioning is a topic. They show increased risk of dislocation in some studies and increased risk of neurovascular complication. So is the minimal invasive approach really worth all the effort? In this study, it's quite interesting. They did an MRI before and after implantation of the hip. Here you have the MRI on the right side and on the left side before implantation, and here after implantation. Here you see a quite difference of the gluteus medius with a fatty atrophy in this picture and without atrophy in this picture down there. And so it's easy to say this was a direct lateral approach and this was an anterolateral minimally invasive approach. What for me was a bit surprise, they used the straight stem for both approaches, also for the anterolateral approach. Here they tried to find a sensitive marker for the muscle trauma. They find the scaletroponin E and measured it pre-op, 6, 24, and 48 hours post-operatively. And they compared the transgluteal with the anterolateral approach, and they find a reduced amortization for the muscle tissue in the anterolateral approach. But again, they used for both approaches a straight stem. And this is also an interesting setting. They took 5 surgeons. Every surgeon operated 5 hips, and with his preferred approach and preferred stem. They have the anterior, anterolateral, 2 incision, posterior, and the traditional lateral transgluteal approach. Afterwards, they took a photo and measured the damage of the muscle computerized. What they find out that the median defect after implantation was in the lateral group 22%, in the anterior group not, and the anterolateral 18, 26, and 18% in the other minimal invasive groups. So you could say there isn't a big effort. There is no big effort of the minimal approach compared to the traditional approach. They also looked at the integrity of external rotators, of nerves and ligaments, and they find, especially for the posterior approach, some detachment of the muscles on the posterior side, and they find, quite interesting, in the anterolateral approach, 3 times a partial defect of the gluteus superior nerve. But if you look a bit deeper, these are the 3 implants which were used and the surgical instructions. And all of these implants are not perfectly designed for a minimal invasive approach. And I think if they have done it with an implant like the Optimus, which is designed for minimal invasive approach, the outcome and result would be completely different. And this study, they compared direct lateral versus anterior approach, 123 hips performed by 8 surgeons. And here they focused not on the Harris-Hips curve, they focused on the muscle activity. They took the stopwatch activity monitor and measured the steps of the patient in the first year after surgery. And what they find out is that after 1 year, direct anterior approach shows a higher activity of the patients. but no difference regarding the hip functions, only a difference in regarding the muscle activity and the activity of the patients. Again, it was not a real straight stem, it was something between it, anatomical stem. Does the approach affect the outcome? Here they did a posterior and lateral approach for 500 hips, then they changed to an anterior minimal invasive approach, and they changed to a short stem simultaneously. And what they find, that they had more complications with the anterior approach in combination with the short stem. And the resume was cautions recommended when changing various aspects of techniques and implants simultaneously. So you should start with the stem first, and then when you're really sure with the stem and with the implant, then you should change the approach secondly. This is a register study from a Norwegian register, implant survival, minimal invasive versus standard approach. They looked after nearly 22,000 hips, 4,000 with anterior and anterolateral approaches, 17,000 direct lateral and posterior approaches. They find the only difference was the posterior approaches has 2 times more dislocations, but the revision rates and risk of revision was completely the same for minimal invasive and for standard approach. So what's the influence of the surgical approach on component positioning? This was the topic of this study. They compared a short stem, a myostem, anterolateral versus direct lateral approach, and they could show that the stem was able to equally restore the acetabular and hip offset, the leg length, the center of rotation, and the stem alignment. But the anterolateral approach shows in nearly 40% a cup malpositioning, which I think has to do with the more technical demanding approach. And thus, stem design influenced the company's positioning with the MIS approach. They compared straight versus short stem and via a posterolateral minimal invasive approach, and they could show that as well as leg length and cup positioning is concerned, there are equal results. And in the offset reconstruction, the short stem is a bit better, but both under 1 millimeter, so it's nearly the same. So what can we say if you summarize the whole results? Not everything in life fits together, and I think it's the same in politics as it is in orthopedic. So not every stem fits to every MIS approach. And if I go back to the first slide, does the approach influence the choice of the implant type? I think it should say the implant type influences the approach. So to summarize, the MIS approach is a technically more demanding approach. It shows better early outcome. Long-term follow-up seems equal to the traditional approaches. In literature, different approaches are compared in combination with straight stems. I think that's a pitfall. They should compare straight stems with short stems in MRS approaches. So the claim is the full advantage of MRS can only be achieved in combination with a short stem, or exactly the other way around. The full advantage of a short stem can only be achieved if you use a MIS technique. I think the winning team is like with Batman and Robin. Both of them could help you individually. But if you have to deal with the real bad guys, I think you need a combination of both. And I think it's the same in hip arthroplasty. Thank you for your attention.